We medical pass through two phases of medical life, that is, from knowing nothing to knowing something. So, highly enthusiastic and dedicated medical students from different colleges all over the Nepal have come up with a platform called the Grey Medicos to conduct interactive teacher-student session with the aim of getting insights and to strengthen our clinical knowledge. Just a little briefing before we get started. All the participants should join with their real name and respective institution. To keep the quality of sound functional, it's a humble request to everyone to mute themselves. If you have any queries during the webinar, please type it in the chat box. Our co-host will acknowledge them after the presentation. On behalf of Grey Medicos, it is a matter of honor and pride to welcome highly credible, competent, and respected delegates of today's webinar as our mentor, Dr. Buddhiraj Pokhrel sir from Department of Biochemistry, UCMS, Dr. Jeson Dhoj KC sir from Department of Radiology, UCMS, Dr. Ganesh Bista, Dr. Ganesh Bista sir from Department of Medicine, UCMS. All our delegates are very humble, polite personality with excellent teaching ability. Now, without further delay, we will turn time over to the presenter. Presenter for today's session is Himal Thapa, final year MBBS student of UCMS. He is very considerate, energetic, and sincere in his field. The platform is all yours, Dai.
Yes, Sri. Good evening, everyone. Dr. Ganesh Bista Dai, Jeson Dai, Dr. Jeson Dai, and Dr. Buddhiraj Pokhrel sir. I am here to discuss about the case. The case is about next. The case is about a patient who presented with severe upper abdominal pain in the emergency department. With appropriate triaging, he was presented to the yellow zone, and I proceed with patient particulars. Mr. X, a 33-year-old married male resident of Bhutol, Buddhist by religion, of businessman, studied up to +2, was presented to the UCMS emergency on 16 October with chief complaint of upper abdominal pain for 3 days and vomiting for 2 days. From the chief complaint, this case might be of gastrointestinal and hepatobiliary system, or cardiovascular, or respiratory, or endocrine. So I proceed with the history of presenting illness. According to my patient, he was apparently well 3 days back when he presented with abdominal pain in the epigastrium. The pain was sudden in onset, continuous, radiating to the back, aggravated while sleeping, and partially relieved on leaning forward, and was of increasing severity, and wasn't even relieved by the medication bought from the local pharmacy. He also complained of nausea with vomiting for 2 days with frequency 4 times a day, non-bilious in nature, non-projectile, non-blood stained, and containing mostly food particle. Discussing about the biorhythm, there is normal bowel and bladder habit with normal sleep pattern, and there is history of early satiety and loss of appetite since 2 days. Next. And to be more systemic, specific, and to rule out other disease, we are going with the negative history. There is no history of fever, significant weight loss, no history of heartburn, regurgitation, nocturnal cough, no history of chest pain. Next. No history of yellow discoloration of eyes, no history of any trauma, no history of shortness of breath, dyspepsia, water brass, altered stool. Talking about the drug and allergy history, there is no history of chronic drug intake and no any known incidence of allergy reaction to the drug. Next, talking about the past history, there is no history of similar illness in the past, no history of chronic illness such as tuberculosis or contact of tuberculosis, hypertension, diabetes mellitus, and no other medical comorbidities, and there is no history of any surgical intervention.
I'd like to ask some questions to you regarding your HOPI and chief complaints.
Yes,
you mentioned that epigastric pain. What type of epigastric pain was there, and how do you differentiate the epigastric pain related to cardiac causes, related to GI causes, and related to other causes from your history and from your evaluation?
Yes, sir. The patient complaint of epigastric pain. First, we have to rule out the causes. In cardiovascular causes, it might be of myocardial infarction. The pain was the pain of the MI is constricting pain and relating to the shoulder, jaw, and in the GI cause, in case of peptic ulcer disease, the pain is also in epigastrium, but the pain is like a wave. It comes and goes, and it is related to the intake of food. And
in case of cardiac cause, if there is myocardial infarction,
yes,
and in case of myocardial infarction, there is pain in epigastric region as well. And what type of myocardial infarction will be there if there is pain in epigastric?
In case of inferior wall MI, there might be pain in the epigastrium region.
Yeah. What are the associated features or sign and symptoms suggestive of myocardial infarction if you are suspecting myocardial infarction associated with?
There will be the shortness of breath, constricting chest pain with radiating towards the jaw, shoulder and jaw, and there might be vomiting also, nausea, vomiting, and shortness of breath mainly.
There can be pain in left arm also.
Yes.
There can be pain in left arm. Pain will be severe, which is not relieving with medications. This, and for that we need to give morphine to suppress the pain. Pain is severe, which persists till 1 hour, and patient may present with chest pain, retroesternal chest pain, which is picking and pricking type, which is associated with dragging sensation over the jaw and dragging sensation over the neck, and chest heaviness, especially over the left side, associated with pain in the left arm, especially over the middle aspect of the left arm. There can be history of sweating as well. Okay.
Yes, sir.
And speaking regarding other causes of an epigastric pain, what are the other differential diagnoses you would like to mention regarding epigastric pain, and how would you rule out other causes?
Other causes of epigastric pain, one you said myocardial infarction, mainly inferior wall MI. Other peptic ulcer disease might be the cause for the epigastric pain, and other small bowel obstruction can also be there. Small bowel obstruction and lower lobe pneumonia can also be there, and acute cholecystitis, biliary colic. And to rule out the pain of the peptic ulcer disease, there is no water dash, no altered stool. In case of peptic ulcer disease, there might be melena in stool, and there is no history of altered stool or black carry stool. And
listen me, I would like to add some points on those differential diagnoses. If there is peptic ulcer disease, there will be history in a patient for a long period of time. History will be of an epigastric pain since a long period of time, and the pain will be mild to severe type depending upon the presentation and condition of the patient, and the pain will not be radiating towards the back and will not be relieving by leaning forward. Okay. And there can be history of intake of NSAIDs as well, if it is due to acid peptic disease. Okay, there can be H. pylori infections, and the patient might be taking medications for H. pylori since a long period of time. These features and these points from the history of the patient rule out that it is not due to acid peptic disease or peptic ulcer disease. Apart from these two differential diagnosis, what can be the other differential diagnosis?
Small bowel obstruction can be there, and since there is no normal bowel habit, there is no constipation, and there is no abdominal distension, it might not be bowel obstruction.
What other differential diagnosis can be there, which are to be included and
lower lobe pneumonia,
very much important?
lower lobe pneumonia can be there, and inferior wall AMI, and biliary colic, and acute cholecystitis can be missed.
Okay. And regarding inferior wall MI, you just told me that inferior wall MI. And how would you diagnose inferior wall MI by observing an ECG? Can you tell me?
Sorry, sir.
How would you diagnose inferior wall MI apart from clinical diagnosis by looking at ECG?
ECG.
It's just for the information.
Lead
In case of an inferior wall MI on ECG, there will be changes in lead 2, 3, and AVF. If it is ST elevated MI, there will be ST segment elevation. And if it is ST segment depression MI or non-ST elevated MI, then there will be ST segment depression. Okay. And other differentials which are important regarding an epigastric pain can be like acute cholecystitis, mesenteric ischemia. And how would you define that these two conditions are not there? I mean, it is pancreatitis. It is not acute cholecystitis. It is not mesenteric bowel ischemia. How do you define it?
Mesenteric bowel ischemia mainly occurs in the old age. We have more risk for atherosclerosis in the mesenteric vessels. And in acute cholecystitis, there is no history of fever, no abdominal distension, and non radiating towards the shoulder. The pain is radiating towards the back.
Listen to me. I would like to add on some points regarding explanation of those differential diagnoses. In case of an acute cholecystitis, there will be an epigastric pain, which can be mild to severe depending on the presentation and condition of the patient. But the pain will not be radiating towards the left back, but there can be pain which is at epigastric region, which will be radiating towards the right shoulder. Okay. In case of an acute cholecystitis, pain will be there at the right shoulder with epigastric region due to common root value of the nerve supply.
Common of theory.
Apart from that, in case of mesenteric ischemia, there can be severe pain in epigastric region as well as in periumbilical region. And how can you say that it is mesenteric ischemia? And for that, you have to ask the history from the patient and patient party. If it is due to mesenteric ischemia, there can be long-term history in a patient associated with atherosclerotic conditions. There can be coronary heart disease, or the patient might be taking medications for heart disease, or there can be coagulation disorders. There can be valvular heart disease as well. Those points give us clue that there is mesenteric ischemia. Okay, these points rule out that it is not mesenteric ischemia. It can be an acute pancreatitis. Now go on, please.
Next. Talking about the personal history, he consumed mixed diet. He is a smoker since last 15 years. Number of cigarette smoke per day is 7. Number of year smoking is 15. Now, calculating the pack years, number of cigarette smoke per day into number of years by 20, and it is 5.25 pack years. And there is history of alcohol. He consumes alcohol on weekly basis since 15 years. He drinks 750 ml of whiskey, which is about 42.5% alcohol. And calculating the units of alcohol, it is 31.88 units per week, which is a standard criteria for a heavy drinker.
Yeah. Let me ask you something. Is there any relevant things or relevant conditions that we ask an alcohol consumption a patient regarding this condition?
Yes, sir. Yes,
is there any role of an alcohol?
There might be the alcohol-induced pancreatitis.
Yeah, tell.
Yes, sir. There might be the alcohol-induced, the acute pancreatitis might be the consumption of heavy alcohol.
What are the most common causes of pancreatitis?
Gallstones,
especially in our locality.
Gallstones,
and others?
Alcohol, any trauma, any surgical interventions like ERCP.
Go on telling other causes also, please.
Some pancreatitis might be hereditary. Autoimmune can also be there, and due to the chronic drug intakes like corticosteroids, alphabet, azathioprine, and due to some viral infections like Coxsackie virus, mumps virus.
So, Himal, I would like to ask one question regarding history of smoking here. Yes. Is history of smoking relevant to the to your case?
Yes, sir. It is somehow relevant because smoking might cause it releases the toxic free radicals, which may be the toxic to the external cells of the pancreas. So it is relevant.
So it is a risk factor for pancreatitis, especially if consumed along with alcohol. The risk is more than 4 times for developing acute pancreatitis than normal person. Yes. Okay, you can move on, Himal.
Family history: both parents are known case of hypertension and diabetes for more than 10 years. As for patient, his father has been taking medication for increased cholesterol, and there is no history of similar illness in the family members. In socio-economic history, he lives in a Paka house, drinks tap water, and he belongs to the upper middle class family, according to the Kupuswamy grading. From the history, there are some differential diagnoses such as acute pancreatitis, peptic ulcer disease, lower lobe pneumonia, inferior wall myocardial infarction, biliary colic acute cholecystitis, etc. Now let's move towards our provisional diagnosis. In general examination, he was ill-looking, conscious, oriented to time, place, and person, heavily built with BMI 26 kg per meter square, lying supine on his bed with blue cannula 22 gauge on his right hand. Next, talking about the vitals, the pulse rate is 88 beats per minute, normal rhythm, normovolumic with no radial and radiofemoral delay. Blood pressure was taken on the right arm at supine position and is 130 by 80 mm of Hg. Respiratory rate is 20 breaths per minute and was abdominothoracic. Temperature is 96 degrees Fahrenheit with 96% oxygen saturation. From head to toe examination, there is no pallor, no icterus, no palpable lymph node, no clubbing, no cyanosis, no edema, no dehydration, and there is no fullness in the left supraclavicular fossa.
Listen, Himal.
Yes,
is there any role of clubbing in case of an acute pancreatitis?
in pancreatitis not that much.
Clogging. What are the causes of clogging?
Clogging in according to the system in cardiovascular cause, infective endocarditis, cyanotic heart disease, and in GI, celiac disease, biliary cirrhosis, in causes of malabsorption, in respiratory cause, bronchogenic carcinoma, lung abscess, and in GI ulcerative colitis, some clogging might be genetic.
I want to direct you towards some autoimmune conditions like inflammatory bowel conditions, ulcerative colitis. These may be associated with some other autoimmune conditions, and autoimmune conditions are the factors responsible for acute pancreatitis as well. So if there is clogging, we have to think regarding such things also. Okay. And one more important things from respiratory cause or respiratory system for clogging is there. We didn't mention this. What can be that?
Bronchogenic carcinoma.
One cause is more important than bronchogenic carcinoma. What can be that?
Lung abscess.
Lung abscess, very good. One more important like lung abscess is there. What
bronchiectasis. Bronchiectasis.
In case of bronchiectasis, it's okay. What can be other?
From the respiratory cause.
Interstitial lung disease, ILD. ILD and lung abscess are the very, very important causes of clogging. Okay. Is there clogging in case of COPD patient?
In COPD, I didn't think so.
Yeah, very good. In COPD, there is no clogging at all. Okay. Is there COPD in case of young patient as well?
Young patient? Emphysema can be there.
Emphysema can be there?
Yes.
Yeah, how can it be?
Smoking is the most common.
Young patients. How can it be there in young patient? I mean, is COPD occurs in below 30 years of age?
Maybe.
What can be that condition where COPD can be present in young age groups also?
Congenital alpha-1 antitrypsin deficiency.
Very good, very good. Excellent, excellent. And regarding bronchiectasis, bronchiectasis can be secondary to cystic fibrosis also. There will be CFTR 506 gene mutation or
cystic fibrosis
regarding CFTR gene. And as we know that cystic fibrosis leads to bronchiectasis. And in bronchiectasis, there can be clogging. Okay. And in case of cystic fibrosis also, there can be pancreatitis as well. So in this way, we have to relate one and another points while taking history.
Okay.
Please move on.
Going to the systemic examination, for abdominal examination on inspection, the abdomen is flat with centrally placed inverted umbilicus. All quadrants of abdomen moving equally with respiration. There is no skin discoloration and no venous engorgement. And in case of severe pancreatitis, there might be the discoloration in around the umbilicus, in flanks, and in the inguinal region, which is if it is present around the umbilicus, it is called Collen sign. If it is present in the flanks, it is called gray turner sign, and if it is present in the inguinal ligament, it is called Fox sign. And
Himal,
since you can
listen to me.
okay.
On general physical examination, you mentioned that there can be Cullen sign and there can be gray Turner sign or Turner sign. Do you know what those signs mean?
Sure.
What those signs mean? Do you know that signs?
Yes,
Why are they called so?
the signs they read
Gray Turner sign.
there might be the hemorrhagic pancreatitis or any retroperitoneal hemorrhage.
Hemorrhage. What is the basic difference between Cullen sign and gray Turner sign?
Mostly it is related to the location. Since Cullen sign is present around the umbilicus, and the gray Turner sign is present in the flanks, and they are the bruising lesions, discoloration of skin.
In case of severe pancreatitis or hemorrhagic pancreatitis, due to collection of blood with hemoglobin, there will be Cullen sign. But in case of gray Turner sign, there will be catabolism of the hemoglobin. Okay. So catabolism, there will be grayish to greenish to brown color collection around the flanks, which is gray Turner sign. These signs indicate that the patient might be in episemia, might be in severe respiratory distress syndrome. Okay. What will you find while doing palpation in case of an acute pancreatitis?
Repeat question. Repeat.
What will you find on palpation while doing general physical examination and while doing systemic examination? What will you find while doing palpation in case of an acute pancreatitis?
In general examination, the patient might be unconscious, disoriented, and in vitals, the vitals may be unstable. Pulse may rise, BP decreases, and oxygen saturation decreases. Respiratory rate might increase.
Listen to me. SpO2 may be decreased. How can SpO2 may be decreased in case of an acute pancreatitis? Can you mention regarding that cause or that point?
If there is complicated or severe necrotizing pancreatitis, there might be the chance of organ failure. So oxygen level can decrease.
And before decreasing oxygen level, organ failure can be there. There are some criteria which are dealing with an acute pancreatitis and for its diagnosis and treatment.
Yes.
And what can happen, which subsequently lead to decrease in SpO2 in a patient.
Respiratory failure.
What do we call that term?
Respiratory failure.
Acute respiratory distress syndrome. And all
ARDS.
Yeah, ARDS is the main cause which decreases SpO2 in a patient. For that, a patient may need ventilatory support. Okay, and apart from that, there can be pleural effusion as well, which is sympathetic pleural effusion. Pleural effusion not due to its own primary cause, but can be secondary to other causes. Okay, where can be the pleural effusion? Over the left side or over the right side?
Left-sided.
Very good.
Mainly left-sided diffusion, of course.
Do you know regarding pleural effusion? What type of pleural effusion are there?
Transitive and exudative.
How do you differentiate these two terms?
We'll do the lights criteria. On the basis of lights criteria, we differentiate.
Is it diagnostic criteria?
It is not fully diagnostic, but it is the most standard criteria.
Tell me the components of lights criteria.
In lights criteria, pleural LDS by serum LDS, pleural protein by and serum protein and LDS level. Its range upper 2/3 or below 2/3 of the upper limit.
And protein?
Protein.
Tell me the ratio of protein in Light's criteria.
Protein 0.5.
What are the conditions of exudative pleural effusions?
Any infections like pneumonia, malignancy cause, or other GI cause such as perforation, GI perforation, acute pancreatitis.
What are the other causes?
Rheumatoid arthritis, Jordan syndromes.
What type of pleural effusions is there in case of TB?
Repeat question.
What type of pleural effusion is there in case of tuberculosis and malignancy?
Exudative.
Oh, these are the main points to be noted while telling regarding an exudative effusions. In case of abdominal effusions, I mean in case of an ascites as well as in case of an pleural effusions, corrections in case of chest. Okay.
Yes.
Now go on, please.
Talking about the palpation, in superficial palpation, there is no rise of temperature, no any superficial mass, tenderness is present. On deep palpation, there is no organomegaly, no guarding and rigidity.
What are the points you mention in case of organomegaly while doing examination of abdomen?
We should do further hepatomegaly, splenomegaly, and kidney palpation.
What are the causes of tender hepatomegaly?
Acute viral hepatitis, infected highlighted cyst, dengue, and pyogenic liver abscess or amoebic liver abscess.
Amoebic liver abscess. What type of splenomegaly is there in case of typhoid, enteric fever?
It is mild, tender.
Yeah. Long abscess associated with liver abscess.
Liver abscess.
Liver abscess associated with
film tender.
In case of liver abscess, not only fine tender, it will be tender. Okay. And what are the causes of splenomegaly?
In splenomegaly, causes related to the portal hypertension, leukemia, Kala-Azar, malaria, and myelofibrosis.
Very good.
And topical splenomegaly syndrome.
Or enteric fever also.
Enteric fever also.
Malaria
and in infective endocarditis also from the cardiac cause.
Is there splenomegaly in case of an acute pancreatitis?
Yes. If there is a complicated pancreatitis, there will be the portal hypertension due to the splenic vein and portal vein thrombosis. It can lead to the consequently megaly can be seen in spleen.
Very good. In case of severe pancreatitis, the patient might go into disseminated intravascular coagulation disorder, and with that disorder there can be here and there haphazard collections of blood, and secondary to that there can be thrombosis in splenic vein, and once there will be thrombosis, distal part of that vein will be affected with blood, and subsequently there can be splenomegaly. Now move on, please.
Next, in percussion, tympanic sound is heard. Next, On auscultation, normal bowel sound heard at the left spino-umbilical line.
Now tell me regarding percussions. What type of sound you will heard in case of percussion if there is an acute pancreatitis?
Dullness can be heard. But if there is complicated pancreatitis, it may lead to the pancreatic ascites. There might be the shifting dullness.
Shifting dullness will be there only if there is collection
of
fluid in the peritoneal cavity. And one more thing you need to know, that in case of in case of some conditions, there can be total obliteration of dullness of the bowel. There will be obliteration of the liver dullness. What are the conditions where there can be obliteration of liver dullness?
Obliteration of liver dullness.
Okay, normally, if the patient is normal, if patient presents to you and you will examine the patient, I mean, you will do abdominal examination. While doing deep palpation, you will find that there will be dullness over the liver area. But in some conditions, such dullness will not be there once you palpate over the liver area in case of an abdominal examination. What can be there?
There might be the problem in the lungs. It might be the case of COPD. Emphysema, there might be also the obliteration of liver dullness.
Listen, in case of some conditions like hollow viscous perforation also, there can be epigastric pain. There can be pain around the umbilicus, which mimics like an acute pancreatitis. And hollow viscous perforation can also be a differential diagnosis of an acute pancreatitis. Okay, and in such conditions, once you palpate the area over the liver, you will not hear dullness of the liver area because liver is solid organ. Once you palpate over the solid organ, there will be dull sound. But once there is hollow viscous perforation over the liver, there will be very much collections of gas. Okay, instead of hearing dullness sound of the liver area, you will hear resonant sound. That term is called obliteration of liver dullness. So in case of hollow viscous perforation, which may mimic an acute pancreatitis in the form of epigastric pain, can cause obliteration of liver dullness. Okay. Now, how can we rule out that it is not acute pancreatitis? Even though there is pain in epigastric region, we can rule out in such a way that there will be pain in the epigastric region, but there will not be raised level of lipase and amylase. Okay. Now go on, please.
Following the systemic examination in CNS examination, before B5, M6, and CNS is grossly intact. In CVS examination, S1, S2, no murmur, and in respiratory examination, normal bronchodilation heard. Now, the summary of the history. A 33-year-old alcoholic male visited to the emergency department with complaint of abdominal pain in the epigastrium. The pain was sudden in onset, continuous, not relieved by medication, and relieved by the sitting and leaning forward position, and with multiple episode of the vomiting, non-bilous, non-blood stained vomitus, and ruling out the other disease. There is no fever, no shortness of breath, no cough, no water breath, no heartburn, and since he is a alcoholic patient and he drinks alcohol weekly basis with 31 units per week, which is the standard value for a heavy drinker. And talking about the clinically, the patient is conscious, oriented, lying comfortably in bed with oxygen saturation 96%, with stable vitals. On inspection, abdomen is flat with no any skin discoloration. On palpation, there is tenderness but no guarding rigidity. And in percussion, tympanic sound is heard. And in auscultation, normal bowel sound heard. And other systemic examination are intact, normal. So from the history and the clinical examination, my provisional diagnosis would be the acute pancreatitis.
Can you define an acute pancreatitis?
Acute pancreatitis is defined as the inflammation of the pancreas characterized by typical history of pain and biochemical threefold rise of serum amylase and lipase and CT finding.
Yeah. Now, what are the types of an acute pancreatitis? Can you mention types of acute pancreatitis?
Yes, on the basis of severity, there are two types of pancreatitis, that is mild edematous pancreatitis and severe necrotizing pancreatitis.
In case of
So, can I have a word?
okay, sir.
Okay, hello everyone. So I just heard the Himal just finished his summary. So from the summary and examination, he told his provisional diagnosis acute pancreatitis, right? From his history and examination only, right? So I think you still need to cover other part also. From one history and summary, from a history and examination, you can say it's a pancreatitis, okay? Because definition of pancreatitis, there should be out of 3 criteria, we should match the 2 criteria, okay? And first criteria is the pain. There is the pain, and we discussed, and Dr. Ganesh discussed and give a good explanation about the other thing. That's beautiful for, especially for you guys, for your student. That was very good. But now pain is there, and what is the next criteria? There is biochemistry, lab parameter. There should be more than 3-4 rise in the serum amylase and lipase, right? And third criteria is that is imaging, that radiological diagnosis. So out of these 3 criteria, if we match the 2, then we say it's acute pancreatitis. Okay. Now you just told from your history and from an examination, you say, okay, that's your provisional diagnosis. Okay, it's okay. But what could be the other diagnosis also in this scenario from your history? Just give me 2 or 3. One. Okay. You just got my point?
Yes, sir.
Yeah. Okay. Okay. Fine. It's a pancreatitis. Okay. But sometimes you should also think from other side also. Okay. What could be other cause also? So from before saying you haven't seen the investigation, right? Just from your examination and your history, you said it's pancreatitis. Okay. Most of the things, most of history examination favors for pancreatitis, but there could be other cause also. Okay. You should keep in mind other differential also, very common differential in close proximity with the pancreatitis. Okay. So okay, anyway, I want to say there should, out of 3, 2, there should be 2 criteria. We should match 2 criteria. So we say it's acute pancreatitis. Okay, that's the problem. Okay, now we'll proceed ahead. So we'll proceed at how to. I will proceed right now. What other investigation you are going to say now?
Differential diagnosis.
Yeah, give me a few differentials. We talked about differential, and Mr. Dr. Ganesh has beautifully explained all those things, all what there could be, what we know. But it's not that there's, just give me all the few differences, important differences here.
Cholelithiasis.
Okay.
Acute cholecystitis.
Okay.
Choledocholithiasis or biliary colic.
So you say choledocholithiasis, right? And okay, carry on. Other. Okay, let's proceed. Okay. What are investigations we're going to do now?
First, we'll baseline investigations. CBC, hemoglobin, and plus we'll also send serum amylase and lipase.
Okay.
And we'll see the values, and we'll also send for the lipid profile, random blood sugar also, and plus we'll also test the renal function test, and liver function test.
Okay. So you have done your lab investigations, right? So let's see the result of lab investigation first and then discuss there. Next slide, please,
Next.
for the lab investigations. Okay.
We send for the investigation, and random blood sugar is transient rise is 202, and there is rise in ALT, AST is also rise,
Okay.
and in lipid profile there is a rise in cholesterol and triglycerides, and serum amylase level is also rise, and
So
in
from the, I would like to interrupt you, Himal, for some time. From the point of view of diagnosis, just like Dr. Jeson suggested, out of 3 criteria, there should be 2 criteria that should be matched to confirm the diagnosis of acute pancreatitis, right?
yes, sir.
So by looking at serum amylase levels that in the slide here, it's 134 unit per liter. So would you suggest it is acute pancreatitis based on this level of serum amylase?
No.
Why not?
Serum, firstly, the level of serum amylase and lipase should rise more than 3-fold. Plus, serum amylase is not that specific for acute pancreatitis.
Why
serum
not?
should send for the serum lipase.
Okay, what could be other diseases that might have serum amylase levels increased?
If there is rise of serum amylase, we should think also other causes such as salivary gland tumor,
Okay,
renal failure, any
okay.
viscous perforation, or
Yeah.
if the patient is female, then there might be the ruptured ectopic.
Yeah, ectopic pregnancy.
Yes.
Other intestinal obstructions also might have increased amylase level, right?
Yes.
Okay, so you have done lipase also in
Next.
lipase पनि गरेको छ हैन?
Lipase. Next.
Next slide, please.
Yes, sir.
Okay, so lipase value is more than 3-fold increased.
3-fold.
Yeah. So can you confirm the diagnosis of acute pancreatitis without doing imaging now by seeing the value of serum lipase? I'm just asking from diagnostic perspective and not from
Yes, sir.
severity perspective.
Yes.
So we can confirm the diagnosis because serum lipase is very, very specific to pancreas itself. Now, please move on. Let us move on to previous slide again, the CBC report. Okay. Here you have increased triacylglycerol level also, right? Increased TG levels. So what is your inference from it?
Either the cause of the metabolic cause might be there for the acute pancreatitis. It is also responsible because it is a predisposing factor.
Okay. Increased triglyceride level itself is one of the important cause of acute pancreatitis, besides alcohol and gallstones. And if it is not the cause, would you still expect this serum triglyceride level to rise?
Yes.
Suppose it is not the cause.
There might be the transient rise, or if it is a case of complicated pancreatitis, there might be the hypertriglyceridemia.
Can you also relate it with the history of alcohol, the increased triglyceride levels? Will a chronic alcoholic patient have increased triglyceride levels?
Yes.
Yeah, they might have increased triglyceride as well as increased cholesterol level. And since our patient, the case we are discussing, is chronic alcoholic, is a heavy drinker, the serum triglyceride level might or might not be the cause. We can't be sure as yet, but we can still expect a dyslipidemia in these patients, right?
Yes.
Now, let us talk about another increased value. And LFT is not increased that much, the AST and ALT values. But what if there is increased, highly deranged liver function parameters? Does it help in diagnosis of your case, or does it support? Why did you do LFT in case of this case?
If the cause of acute pancreatitis is gallstone or obstructive cause, then these enzymes might increase.
So doing LFT helps us to locate its origin, right? So if it would have been gallstone, LFT parameters might have been deranged. Now let us move to another CBC. If you are suspecting acute pancreatitis, DLC is really not needed, okay? Differential count, but for other infectious causes, you might need differential count. But if you are suspicious of pancreatitis, differential leukocyte count is really not needed. But but other parameters of CBC are very, very helpful. So would you like to explain on that?
Platelet count is also important, and if it is a case of severe acute pancreatitis, then the patient may go on DIC, and there is more consumption of the platelet, and platelet might decrease. And in WBC, it is a marker of inflammation, simply the inflammation, and hemoglobin level is normal.
One thing I have missed, please go to the next slide. So in CBC, we have missed some hematocrit levels here, right? The hematocrit levels is also really necessary to find out the etiology or complications of acute pancreatitis. So you should, when you are giving complete blood count, hematocrit value is very, very helpful, okay? So do not miss that next time. Okay, we'll discuss other laboratory considerations later on. We can move forward now.
From the history, clinical examination, and the lab investigation, and fulfilling the two criteria of the acute, from the definition of the acute pancreatitis, it is the case of acute pancreatitis.
Now that we have diagnosed the case as acute pancreatitis, let's get familiar with this disease and its etiopathogenesis. To give us insights regarding acute pancreatitis, I would like to hand over this platform to Dr. Buddhiraj Pokhrel, sir, from Department of Biochemistry, UCMS. All over to you, sir.
Thank you, Shreya. Please put the slide on. Okay, good afternoon, everyone. I'm just trying to discuss things about how acute pancreatitis does occur in a very, very simple language before discussing the diagnostic part by Dr. Ganesh, and management part by Dr. Ganesh, and radiological part by Dr. Jeson. I would just like to give a brief outline of how acute pancreatitis occurs. Okay, so we all know the pancreas. The word pancreas itself comes from a Greek origin. It is derived from two words, pan and krias, spelled KREAS. Pan, you all know, means all, and krias means flesh. So it is really a spongy organ which is located at the upper left abdomen of our body, and it is divided into four basic parts: head, neck, body, and tail, and surrounded by very, very important structures like spleen, liver, and intestine. And we should also not miss out the important blood vessels that surround here. And the important part will be covered, I think, by Dr. Ganesh, but I'll just like to outline the important vessels. So we should not miss superior mesenteric artery, inferior mesenteric artery, as well as the celiac axis, and portal vein, which are the surrounding structure of pancreas. Okay. So from functional point of view, why is pancreas? I just read quotation today by one Japanese doctor, and he said that pancreas is actually the most complicated organ of the body. I don't agree with him. I still think brain is the most complicated organ, but still I do agree that pancreas is complicated. And one of the reason it is complicated is because it has both exocrine and endocrine functions, as we'll see in our next slide. So if we divide pancreas functionally, so most of the part, almost 95% of the part, as you can see in the structure here, the fleshy structure, the yellowish structure that you can see is made up of exocrine pancreas. Exocrine pancreas are the pancreas that secretes digestive enzymes and all the alkaline materials that help in digestion, that help create alkaline environment. And the endocrine part, as you can see, some star-like blues, star-like dots there. They are collectively called as islet of Langerhans cells, and they come in at least 4 varieties, and they are discovered so far. So among these 4 varieties are alpha cells, beta cells, and pancreatic polypeptide, or sometimes known as PP cells. So they are endocrine in nature. You know, alpha cells secrete glucagon, beta cells secrete insulin hormone, very, very important hormone. But from the acute pancreatitis point of view, the really important part is exocrine pancreas. So exocrine pancreas, if you see the enlarged section here, is made up of acinar cells, which directly connect, which directly deposit their digestive juice to pancreatic duct. So the here I must also mention some protective mechanism. Although pancreatic juice is very, very important for the digestion and digestion of food, mainly pancreatic lipase, trypsin, all types of biomolecules, actually digestion of every type of biomolecules. But intrapancreatic secretion of these very digestive enzymes is very, very, very harmful. So these are the exocrine secretions: bicarbonate to make environment alkaline, lipase, amylase, which also have diagnostic and prognostic value, trypsin, chymotrypsin, and the proteases, phospholipases, deoxyribonucleases. These are the enzymes secreted by pancreas. And let me tell you that all of these, most of these, not all, but most of these enzymes are secreted, are stored inside zymogen granules. They are the granules where they are stored are called zymogen granules in an inactive form, so that they can be activated only after they are released in intestine. What happens if they are activated inside the pancreas? If zymogen granules get burst and if trypsin and chymotrypsin gets activated inside the pancreas itself and not in the intestinal lumen, that is what is the precursor for acute pancreatitis. Now let us talk about epidemiological part, just to make you realize that acute pancreatitis is really a very, very common disease. That is why it deserves discussion over and over. I would like to make acute pancreatitis discussions and acute pancreatitis being done 1 or 2 more times again, because it is a very, very common disease you are likely to see in your clinical days. Okay, so these are the data that suggest that it is a common disease. So annual incidence, this is from American data, is 13 to 45 per 100,000 molecule. It was data from 2015, but a recent data from 2020 itself suggests that the 13 to 45 is really an underestimate. It is about 600 to 700 per 100,000 people. In America itself, there are 200 to 1,000 to 250,000 hospital discharges per year. However, when I searched for the data from Nepal, there were certain hospital-based studies done, but really on a very, very small scale. So if any of you guys are interested in research, this is a starting topic. This is a very good topic to start. You will be helping your medical community by doing research, at least epidemiological research. I would suggest a multi-centric study through maybe your team, or maybe make another research team and do a good collection of data regarding acute pancreatitis, because it is very, very helpful. It will be very, very helpful to understand the scenario in Nepal. So what basically acute pancreatitis is that, as I told you, there are certain protective mechanisms that helps the proper release of digestive enzymes. Digestive enzymes are secreted by acinar cells. They are stored in zymogen granules, stored in a very protective way. Most of these enzymes are secreted in inactive form called zymogens, right? And if they get activated inside pancreas due to any causes, the common causes we have already discussed: alcoholism, gallstone, increased triglyceride levels. These are the common causes of acute pancreatitis. And if due to any cause, the trypsin, especially the digestive enzyme trypsin, because the sequelae of activation of enzyme is such that first trypsinogen, which is an inactive form of trypsin, is converted to trypsin, and trypsin then activates other type of digestive enzymes. That is a sequelae of activation of enzymes. And if it happens, if trypsin and other enzymes get activated inside pancreas itself, pancreatic parenchyma itself, then it will lead to autodigestion of pancreas, which will again be followed by severe inflammatory reaction, which we will be discussing later on pathogenesis in detail. So this is a nutshell. I hope you get my point. Pancreatic juices are to be secreted, activated only in intestine and not inside pancreas itself. And if they are activated inside pancreas itself, there will be autodigestion of pancreatic parenchyma, leading to inflammatory response causing acute pancreatitis. Now let us discuss the causes of acute pancreatitis. The three major causes have already been covered: alcoholism and gallstone. In certain countries, alcoholism is the most common cause, and in other countries, gallstone is the most common cause. We still don't have definite research what is the case scenario in Nepal, whether alcoholism or gallstone is the cause. Another cause, which might also be due to alcoholism itself, is increased triglyceride level. Iatrogenic cause is also very, very common, especially the endoscopic procedures like ERCP, if done improperly, might lead to acute pancreatitis. There are certain drugs that directly affect the acinar cells that make like azathioprine, sulfonamide, estrogens, tetracyclines, anti-HIV medications. All of these drugs might cause direct acinar injury leading to acute pancreatitis. Then direct blunt abdominal trauma and post-operative causes these are the very common causes of acute pancreatitis. So we'll now discuss some less common cause. Hypercalcemia is one of the less common cause. There are very less incidence of hypercalcemia causing acute pancreatitis. In fact, if we talk about serum calcium level, during most of the acute pancreatitis, we expect calcium level to be lower. And this is supposed to be some sort of protective mechanism by body itself. Then there are other less common causes like vascular causes, pancreatic cancers, pancreas division, and genetic causes are although very rare. The most of the discoveries of the mechanism, pathogenesis of pancreatitis was discovered due to genetic causes. And as Dr. Ganesh aptly put out, the mutation in CFTR gene does not only cause cystic fibrosis or bronchiectasis, but also acute pancreatitis. This is nothing but a This is an anion bicarbonate, chloride bicarbonate exchanger channel, and mutation in this also later is a very, very rare cause of acute pancreatitis. And another cause, Himal has already happily suggested that renal failure might also be a cause of acute pancreatitis. Now moving on to pathogenesis. We are talking about the commonest cause. So let us start from ductal obstruction. So ductal obstruction, irrespective of any mechanism, irrespective of whether it is due to calculus formation, stone formation, or whether it is due to stenosis, or whether it is due to stimulation of any sphincter of Oddi, or any causes, any etiology that cause duct obstruction will lead to blockage of pancreatic secretion. It's a given, and it's a very common sense thing. So I will not explain more than that here. Now, what happens is, now the pancreatic juices, the digestive juices in the acinar cells that are present in zymogen granules, their exocytosis is hampered due to blockage. Now, what happens now is that if their exocytosis to the duct, pancreatic duct, is hampered, then they start fusing with intracellular lysosomes. And you know, lysosomes contain many, many hydrolytic enzymes. So now zymogen granules that contain digestive juices now combine, fuses with lysosome that contains hydrolytic enzymes. So we call that organ autophagic vacuoles, and there now the digestive enzymes come directly in contact with lysosomal enzymes. One of the lysosomal enzyme, cathepsin B, it has a very diagnostic value in other diseases, but here it is a pathogenic. It is one of the important steps in pathogenesis of pancreatitis. So the lysosomal enzyme cathepsin B now activates trypsinogen to trypsin. So now trypsin is activated inside the pancreas itself. In normal case, trypsinogen would be activated to trypsin in intestine by cholecystokinin and other ductal cells, other contents of ductal cells. But in case of blockage, when they cannot be exocytosized, this lysosomal enzyme is also capable of activating trypsin. So activated trypsin now starts activating all the other digestive enzymes that are present in its zymogen or inactive form. So this leads to autodigestion, leads to acinar cell injury. But there can be certain instances where there might be acinar injury, direct acinar injury, and not due to ductal obstruction. For example, if toxins are secrete, various toxins, hypoxic injury, or sometimes very rarely infectious causes of acute pancreatitis might also lead to the acinar cell injury. What happens after acinar cell injury? There will be severe inflammatory response. Neutrophils and macrophages are now, there will be infiltration of neutrophils and macrophages that will attract various cytokines like interleukin-1, next slide please, interleukin-6 and interleukin-8, as well as tumor necrosis factor alpha. And this elicits an inflammatory response leading to acute pancreatitis. Now let us discuss about alcohol and acute pancreatitis. Next slide, please. So as we know, alcoholism is one of the major causes of acute pancreatitis. So it has three distinct mechanisms of causing acute pancreatitis. One is it acts as a toxin to acinar cells, and there will be direct acinar cell injury. Another, it causes precipitation of certain protein secretions and leads to formation of protein plaque. These protein plaques now start calcifying. They form calculi and then lead to the obstruction of duct itself. So it has both obstructive cause as well as toxic cause, leading to the acinar cell injury, eliciting inflammatory response. And another, alcohol also increases digestive and lysosomal content within acinar cells. So there will be high chance of fusion of chymogenic granules and lysosome, leading to the activation of trypsin or the cytotrypsin itself. So that is all about pathogenesis. Now I would like to hand over the platform to Dr. Ganesh again for the diagnosis of acute pancreatitis.
Thank you.
Knowledge and acute pancreatitis, let's move forward to its diagnostic procedure. So now I will hand over this platform to Dr. Ganesh Bista, sir. All over to you, sir.
Thank you. Now moving on towards diagnosis on the basis of revised Atlanta classification 2012, and it mainly comprises of following features for the diagnosis. For the purpose of diagnosis, first of all, we have to mention abdominal pain. Abdominal pain is consistent, acute in onset, which can be severe in epigastric region, which is especially radiating towards the back, towards the left back, and pain is such a pain which is severe and difficulty in resisting even with medications. It mimics pain of MI as well, as we have already discussed previously also. And one of the peculiar feature of this pain is it gets relieved once the patient leans forward. The basic reason behind it is once there will be connection between inflamed pancreas and peritoneum, parietal peritoneum, there will be sensitization of the pain sensitive receptors, then the patient presents with pain. Once the patient leans forward, then there will be creation of gap between the inflamed pancreas and the peritoneum, so that the pain will be relieved. So in case of an acute pancreatitis, there will be severe pain in epigastric region, which is radiating towards the left back. And along with that, there will be a raised level of serum lipase and amylase. Lipase is more sensitive as well as specific, and it is raised more than 3 times from the normal upper range in serum. Serum lipase as well as amylase, both will be raising more than 3 times the upper limit of their normal upper range serum levels. And along with that, there will be characteristic findings regarding an acute pancreatitis, which will be revealed by means of CECT abdomen. And for doing CECT abdomen, first of all, the RFT of the patient should be normal, because there can be contrast-induced hypersensitivity reaction in case of patient if there is deranged RFT. And apart from that, we can do MRI, but it is not done commonly. We can also do transabdominal ultrasonography as well. And regarding this CCT, MRI, and ultrasonography findings, I would like to request Dr. Jeson sir to mention further regarding those examinations and their clinical and their findings.
So good afternoon, everyone, once again. So as Dr. Ganesh has told, this is the main diagnostic criteria revised at the class of 2012, right? So in our case, let's examine in this case, he has epigastric pain and his biochemistry is right. So is already diagnosed as pancreatitis, right? So what's the role of imaging? What's the role of radiology department in this case? When to do the CT, when to do the ultrasound, and what are its indication and what benefits we get from it, right? We want to learn that thing. So first of all, it's a case, it's like he has pain, his life is normal, increased. So in our center, we usually do the ultrasonography because it is the most common, easily available, and we can do it. But role is not so clear like the CT and MRI, but for we can say we can usually use it as a screening purpose. Okay, for screening purpose, for some literature say it's a screening purpose, or we can, it's not for like for 2 criteria is there and the remaining is showing, we don't need for what we find in the ultrasound in the initial phase is the bulky pancreas. That is, the pancreas is swollen pancreas, right? Because in pancreatitis, it's the pancreas is angry and started autolysis of its own cell. So that's result in the bulky pancreas. So how can we say it's a bulky pancreas? So for that, we should know the size of the pancreas. Okay, size of the what the size of the head, what's the size of the body, what's the size of the tail. So normally the size of the head size is it's 2.5 centimeter. If it's more than 2.5 centimeter, which is the head is increased, size of head is increased, and the size of the neck and tail is usually 1.5, and neck and body is 1.5, and tail is usually 3.5. It's more than 3.5, so it's a bulky pancreas. Okay, so we see on what we see on ultrasound is the size of pancreas is increased with, there may be some collection around the pancreas that we usually term it peripancreatic collection with nearby, and there is inflammation nearby the place, so there is the fat strandings. So if you find this thing in ultrasound, we say it's a pancreatitis. Now, when to do the CT, when to do the CT of this patient? So usually we say we should perform CT after 3 to 5 days, after 72 hours. Why? So because if we initially we do the CT, then we can just we'll find some swollen pancreas, and we cannot differentiate between the acute edematous pancreatitis and what next is the necrotizing pancreatitis. So the role of CT here is for the usually is to differentiate between the acute edematous pancreatitis and the necrotizing pancreatitis, and it's later on we'll use it for the complication. And the next thing is the main role of CT in the case of pancreatitis, it will say the severity of the pancreatitis, how severe is that pancreatitis, and it will help for the management, especially for the other team. It will guide for the management. If it's so, there are a lot of criteria, a lot of things so we need to know. But for your level, just initially, just remember few things. It's for to differentiate between the edematous pancreatitis and the necrotizing pancreatitis, and after all, and the next one is it will guide for the treatment in a sense. It will grade the severity, and that will help the treating physician to guide the treatment for the further treatment. Okay, next slides. Let's proceed to next slides.
Now,
so
okay,
I think this is the severity assessment. Usually mild, moderate, and severe. Wait, next slide. Next. So okay, let's start with the ultrasound. Okay, back slide. So it's a glute screening test in mild disease and used to exclude a diagnosis of gallstone. Okay, we talked already what's the role of ultrasound here. So the most common cause of pancreatitis is gallstone. Okay, so it will help. This is a very beautiful. It will help you to find if there is a gallstone or not. If there is a gallstone in the neck of gallbladder or any place in the biliary tract, then that may lead to the pancreatitis. So it will help to find the stone to rule out other cause. One of the most important cause is gallstone. And the next slide. So here is back slide. So this is again. Slide, next slide. So okay. Okay, I'll tell you how can we differentiate from acute edematous pancreatitis from acute necrotizing pancreatitis. Okay, from the CT especially. So what we will see in the acute edematous pancreatitis, there is a bulky pancreas. The pancreas size is increased. Next, the size of pancreas is increased, and with there is enhancement of the pancreatic parenchyma. So that will help to differentiate between acute edematous and in necrotizing pancreatitis. When you give the contrast to the patient, then there will be non-enhancing, because the necrosis itself, there is the dead neck pancreatitis, so it won't enhance. So this main the difference out. This is the thing how we as a radiologist we differentiate between acute edematous pancreatitis and the acute necrotizing pancreatitis. Okay, so after we say that it's acute edematous pancreatitis, so then what we should do? So what are the complications? What happened after that? What will happen? How it will proceed ahead? So if it's case of acute edematous pancreatitis, then there is a chance of acute peri-pancreatic collection is noted around the pancreas within less than 4 weeks time. Later on, after 4 weeks, 1 month, it will change into pancreatic pseudocyst. Okay, and in case of acute necrotizing pancreatitis, there is acute necrotic collection around the pancreas, and later on after 4 weeks it will change into wall of necrosis. Okay, so this is the main thing. So what's the role of imaging is to differentiate between, first of all, to differentiate between the acute edematous pancreatitis and necrotizing pancreatitis, and it's the later, it's the complication, how we will find its complication. Okay, so in our case, this is the case of acute edematous pancreatitis. So you can see the picture here, though it looks so big picture, there are a lot of pictures. So I mean, in this case, in our patient, the patient has, it's a case of acute edematous pancreatitis. So we see the enhancing pancreas when you give the contrast. So we say it's an acute pancreas. So what will happen now? It's a case of acute pancreatitis. Okay, acute edematous pancreatitis. So what's the role of imaging? Means we will help to know what is complication and its a severity, and later help is the guiding treatment person. Okay. It's the same, the acute edematous pancreatitis. It's the acute inflammation of the peripancreatic parenchyma and pancreatic tissue, but without recognizable tissue necrosis. So what we see in CCT, localized or diffuse enlargement of pancreas. The same thing with hormonal enhancement of slightly heterogeneous enhancement of the pancreas related to the edema. Okay. And okay, see, let's see the picture. Okay, the picture itself speaks about itself. So you can see the arrowhead here. The pancreas looks so big, it's so bulky, it's the size is more than its size, and there is around its pancreas there is inflammation, so there is peripancreatic fat strandings. Okay, and we see on contrast CT there is enhancement. This you can see here, my cursor here, there the enhancing pancreas here is all in. So this is the case of acute edematous pancreatitis. And the next type is necrotizing pancreatitis. So inflammation associated with pancreatic parenchyma or is necrosis. There is necrosis. The pancreatic tissue is dead. It's dead. So there is no any blood supply. All that are dead. So when you give the contrast, then it won't enhance. This is the main thing we'll differentiate between acute pancreatic. It's whether it is edematous or it's a necrotizing pancreatitis. Okay, if it enhances, that is edematous. If it doesn't enhance, it's a necrotic. Necrotic in a sense, how we'll say. So you can see in there in the picture, the pancreas looks bulky. It's so bulky, and here there is non-enhancing thing. It's not enhanced. It's not. So it's a case of acute necrotizing pancreatitis. And okay, then the acute peripancreatic fluid collection. It's also one of the, we should know the area of peripancreatic seen within the first 4 weeks after onset of indication in the pancreatitis, and without the feature of a pseudocyst. After 4 weeks, it will change into the pseudocyst. Okay, in case of acute edematous pancreatitis, and in case of acute necrotizing pancreatitis, it will change into acute necrotic collection. Later on, it will change into walled off necrosis. Okay. So here, pancreatic pseudocyst. Okay, this is the case of pancreatic pseudocyst. So our imaging department, first of all, it's help to find the complication of pancreas. How we can say it's a pancreatic pseudocyst. Okay, now the CT criteria is well circumscribed, usually round or oval. Don't go for the homogeneous fluid density. So in pancreatic pseudocysts, the content is homogeneous and there is no any debris. Okay, and it have a wall, it will the enhancing wall. So we call, main thing is we should look the inside, what's inside this collection. You can see the arrowhead, there is no any debris, it's just only fluid, homogeneous fluid density with a thick wall around the pancreatic. So this is the pancreatic pseudocyst. And the next thing is, now the case of wall of necrosis. In the case of necrotic pancreatitis, this is the case of wall of necrosis. You can see the thick enhancing wall within an inhomogeneous density within the content, and there is some hypodense area. This is the black thing. This is the hypodense. Sometimes it can be fat. Sometimes, so they define there is the debris inside it. So this is the case of wall of necrosis. So usually what we see, if it's inside the pancreatic parenchyma, it's not a pseudocyst. It's most of the time it's a wall of necrosis. So what I want to focus you here is what's the use of saying this is pseudocyst and this is wall of necrosis. So it will help to in the management of this thing. If it's a pseudocyst, then we can do USC guided. We can drain it out to the USC. And if it's a wall of necrosis, then we need to do big bore hole, we'll drain with a big bore hole, or we'll do the surgery. So it's just a part of surgical procedure. Okay. And next, okay, that's I think it's from my part. I'm going to hand over to the Dr. Ganesh for his further.
Thank you, Dr. Jeson KC. Now I'd like to proceed further regarding acute pancreatitis management.
The assessment slide, please.
Before that, I would like to go back on the previous slide, which was related to scoring system, Marshall modified scoring system. Now, for the scoring purpose for an acute pancreatitis, we nowadays follow modified Marshall's scoring system. It has 3 components. It involves 3 systems: respiratory system, renal system, and cardiovascular system. And in these systems, if there is a score of 2 or more than 2 in any systems, then it confirms that there is an acute pancreatitis. And in these systems, in case of respiratory system, we consider partial pressure of artery out of fraction of inspiratory air. And in case of renal system, we consider serum creatinine level. And in case of cardiovascular system, we take systolic blood pressure level. And for the diagnosis purpose, if there is respiratory quotient in the ratio of 201 to 300, then there will be a score of 2, which is diagnostic point. And in case of renal system, if the creatinine level is around or more than 2, then it can be considered as an acute pancreatitis. And if there is systolic blood pressure level less than 90, but which is refractory, it means it is not responsive to fluid. Refractory means refractory to fluid, not for the medications. And then it can be considered as severe pancreatitis. So in case of Marshall scoring system, we basically consider 3 systemic considerations, like respiratory partial pressure of oxygen arterial out of FiO2. And in case of renal systems, we take serum creatinine level. And in case of cardiovascular system, we consider systolic blood pressure. Now moving to the other slide. Now there is some points related to amylase and lipase, and for that purpose, I would like to request Dr. Buddhiraj Pokhrel sir to proceed some relieving points related on those topics.
Thank you, Dr. Ganesh. Actually, the laboratory part has been very adequately covered by our Himal bhai. So thank you for that. So as we said in our revised Atlanta criteria, one of the major most important criteria is the level of serum lipase or amylase. it should be more than 3 times the upper limit of normal range. But it doesn't mean that if there are, let me give you example of two scenario. In one case, the lipase, serum lipase or amylase is increased 4-fold, and in another case, the serum lipase or amylase is increased 10-fold. The case where the lipase is increased 10-fold doesn't mean that it is more severe type of acute pancreatitis. Severity of acute pancreatitis depends totally on other criteria as discussed by Dr. Ganesh. So serum amylase, amylase is probably one of the only enzyme that easily crosses glomerular filtration barrier, and serum amylase level usually returns to normal level, baseline levels during after 3 days, 3 to 5 days. So if the patient comes really late, maybe after 5 to 6 days, and you don't have serum lipase to access, then suggesting urinary amylase estimation would also be a good idea. That was the slide about urinary amylase. But if you have option, serum lipase is the most specific marker for acute pancreatitis, and go for it. If you have to choose between amylase and lipase, just go for lipase without second thought. So its normal level is 0 to 160 units per liter.